Good morning, everyone. I'm Dr. Deepa Ponnaiyan, Professor, Department of Periodontics, SRM Dental College, Ramapuram. So today's topic, we're going to learn about clinical diagnosis. So what is diagnosis? Diagnosis determines whether the disease is present. It identifies its type, extent, distribution, and severity, which finally helps us provide an understanding of the underlying pathological processes and its cause. So what are the different types of diagnosis we know of? So first one is provisional diagnosis, then your differential diagnosis, and final diagnosis. The provisional diagnosis is also called as a tentative diagnosis or a working diagnosis. It's also formed after you evaluate the case history and you have performed your clinical examination. The differential diagnosis, on the other hand, is just a process where you're listing out two or more diseases which have similar signs and symptoms, or which only one could be attributed to the patient's disease. So for example, if you're saying some periodontitis, you're not sure whether it is chronic, so you might give it as an aggressive periodontitis case if you see that the symptoms are same. Then what is final diagnosis? So final diagnosis is after you've made all your chronological organization, you've done critical evaluation of all the information that you've obtained from the patient history, your physical examination of the patient, your clinical examination, and the result of your investigations, which could be your radiological investigations and your laboratory examinations, like if you've done any blood investigations. So when you see the patient, what is the first thing you do? You take in your case sheet, most of you all recording your short case sheets or your long case sheets. So how do you go about it? So first thing you do is you record the patient's demographic data, which means you just take patient details, name, age, sex, occupation, and address. So what is the name, how it's going to? So whether the patient is a male or female patient, what is the occupation? Then you take a chief complaint. What is the patient's complaint? What has he made him seek dental treatment? Then you take the history of that complaint. Then you take a past dental history and you take your medical history. So history forms a very important part of your case sheet and it has to be thorough. So see that you are taking each of these components thoroughly. Post which you also ask the patient if they have any drug allergies, if they have any family history, and then you ask about their personal history. What is their oral hygiene? What kind of habits do they have? Any deleterious habits, like if they're a pan chewer, if they're a smoker, alcoholic, so all of those things. Okay. So once that is complete, we then proceed to the examination of the patient. Examination of the patient includes general examination where you see for the vital signs like your pulse, blood pressure, temperature, respiratory rate, and if the patient is anemic. So once all of this is complete, then we go for the extraoral examination. The extraoral examination is basically you see the facial symmetry. You have to check for the lip competence, whether it's competent or incompetent. You check for lymph nodes. And then you check for the temporomandibular joint. So temporomandibular joint, you have to check for any clicking noises or any deviation. Intraoral examination comprises of hard tissues and soft tissues. Now the hard tissues are the teeth. So we need to examine the number of teeth, the missing teeth, decay if there is, and any wasting diseases. Now, what are wasting diseases? This is very important for us because as periodontists, we also see how these diseases, wasting disease of the teeth, they affect the periodontium. So you have to check for, the first picture shows you what is this? This is attrition. So there is wear of the tooth because of occlusal, excessive here occlusal forces. And here you could see there is completely worn out incisal edges. Then you have something called as abrasion, which is because of faulty tooth brushing. We call it a cervical abrasion. Then you have something called as erosion. Now, erosion is more of a chemical process. That is because patients may be taking a lot of acidic foods or they may have a gastroesophageal reflux. So when this happens, a lot of acid reflux erodes the palatal surfaces of the teeth. Then we have something called as abtraction. So abfraction is when you have occlusal forces, which is causing flexion and breakage of the enamel at the cervical region. So these are all the wasting diseases of the teeth. Then we have to check for something called as plunger cusps. Now, what are plunger cusps? So when you have a sharp cusp, sometimes when the opposing teeth have an open contact, opposite tooth cusp could be sharp and could be plunging the food in between the interdental areas. So that could lead to food impaction. So this is important that we identify teeth which act as plunger cusps, and we need to eliminate. So what is the other things we know of? So the hypersensitivity, which you see here, the patient can have extreme hypersensitivity. It can lead to stains, plaque formation, calculus formation. The patient can also have migration of teeth, and they could have sensitivity to percussion. So we need to check for all of this when we're doing a hard tissue examination. Now, the next important thing for hard tissue is occlusion. We need to check whether the patient has a normal occlusion or not, whether the patient has a proclination, whether he has an open bite or deep bite. So please check for the occlusion as well. Next, we check for something called as trauma from occlusion. Now, you all know what is trauma from occlusion. So it is the tissue injury that occurs when you have an excessive occlusal force. The test that we use for this is called the Fremitus test. Now, Fremitus test helps us to check for this trauma from occlusion. Of course, you can use also occlusal registration strips. So what is basically done here is we keep a gloved finger on the labial surface of your maxillary anteriors. You then ask the patient to open and gently close. So when the patient does that repeatedly, you will feel vibrations on your index finger. So these vibrations are felt on the maxillary surface of your anterior teeth. Next, we check for tooth mobility. The tooth mobility, we need to know the underlying causes for tooth mobility. What causes this? What is physiologic mobility, pathologic mobility, and you also have to grade your tooth mobility. So how do you check for tooth mobility? You check whether the mobility is very minimal. If it is minimal horizontal mobility, which we say is degree 1. If it is more than 1 mm, it is degree 2. And if it is mobility in the vertical direction, we call it as a grade degree 3 mobility. Now, how do you check for tooth mobility? It's very simple. You use the handle of your instrument and you use your index finger on either side, and you try to move the tooth in a labiopalatal or a buccolingual direction. So once you do this, you then check adjacent tooth in respect to that, how much the tooth is moving. Next, we come to the soft tissues. Now, the soft tissue examination is either the lining mucosa you check, that is the buccal labial or mucosa, the palate, the floor of the mouth, or the tongue. Then you also check for color, surface texture, the consistency, and if there's any swelling in the soft tissues. So you have to check thoroughly for the soft tissues. If there are any lesions or anything that you see, you must record it there. Next, very important, we check for gingiva. That is part of the soft tissue examination. You need to check for the color, the contour, the consistency, the surface texture, the position, size, and if there is any exudate. So we all know what is the color of gingiva. Color of gingiva is usually coral pink. This is in health. Sometimes in our population, we do find there is a pigmentation, as you can see in the picture down. So this is not any disease, but it is just a melanin pigmentation. So in that time, the color will be different. In other instances, when you have inflammation, you will have a florid red color of the gingiva, which is obviously sign of inflammation. Sometimes you could also have like a pale gingiva. If patient could have some kind of desquamation, you will see that a whitish color is seen. Okay. So next you check for consistency. So consistency of the gingiva in health is firm and resilient. And sometimes when you have gingival enlargements, so when the gingiva is highly enlarged, that time the consistency becomes soft and edematous. So we see that there is a lot of edema and inflammation, and the gingiva is highly enlarged. So next you check for the contour of gingiva. So what is the contour is? It is the shape of the gingiva, how the gingiva adapts to the tooth structure. So the gingiva contour is usually scalloped. So we see there is a C-shaped gingiva that goes all around the tooth. That shape is called as a scalloping. So in health, we see scalloping, and sometimes when you have recession or you have inflammation, you may have a lesser C shape. You have more of flattened gingiva. So that you need to record. So that is a sign of inflammation. Then, of course, you see the size. The size of the gingiva, normally it should be like this. If there is inflammation, it is increased. You have here, can you see a bulbous enlargement of the interdental papilla? Here you can see again a gingival enlargement. So all of these things need to be recorded. Next, coming to the surface texture. Surface texture of gingiva means the stippling. So when you have this orange peel-like appearance, you can see here, this is seen here on the attached gingiva and all inside this interdental, center of the interdental papilla. When you dry the gingiva, you see these alternate elevations and depressions, which is called as a stippling. Now, this stippling is absent on your marginal gingiva, and it is not there in the sides of the interdental papilla. It is there only in the center and all of your attached gingiva. Okay, so you need to record if there is a presence or absence of stippling. Then we check for bleeding on probing. Now, bleeding on probing is checked by when you probe into the gingiva and you generally run the probe along the sulcus, you check if there is any bleeding. So positive bleeding on probing implies that there is underlying gingivitis or there is starting of gingival inflammation. Exudate is generally by digital pressure. We press the gingiva sulcus or we try to run the instrument gently from the base to the apex of the gingiva. This is just to allow if there is any exudate, any fluid will be expressed out of the gingival sulcus. So this is seen when there is a lot of subgingival calculus or there is inflammation. Then the position of the gingiva, normally we check it should be above the cemento-enamel junction. So you know what are the parts of gingiva here. So this picture is showing you where the gingival margin should be located. So if your gingival margin is located apical to the CEJ, this picture shows you how a normal gingiva is, and this is showing you when there is a recession. So this versus this, if you see, the gingiva has come down more apically. So there will be underlying bone loss or there will be soft tissue loss. So recession is also a sign of periodontitis. So recession can be classified here according to P.D. Miller's as class 1, 2, 3, 4. And it also can be according to Sullivan and Atkins classification. So once you've identified it, you need to classify the recession. Then very important observation in your clinical diagnosis, which will help you to understand disease, is your probing pocket depth. Now the probe is gently inserted into the gingival sulcus, always parallel to the long axis of the tooth. And then when you insert the probe, you check how much the probe is going into the sulcus. So the probing depth is usually taken from your gingival margin till the base of the sulcus. So wherever your gingival margin starts, from there you will start recording your pocket depth. So this is a very common question many of the students ask. What is probing pocket depth versus clinical attachment level? Now, please remember, clinical attachment level is also measured, but it is from a fixed point. It is taken from always the CEJ to the probable depth of the pocket. That is the base of the pocket. Whereas your pocket depth is recorded from the crest of the gingiva, the marginal gingiva, to the base of the pocket. Then finally, after you've done your intraoral examination, your hard tissues, your soft tissues, you've checked for your gingiva, you also check for one more important thing, which is a mucogingival problem. So this mucogingival problem is in the form of frenal attachments or inadequate width of attached gingiva. So here you can see a picture which is showing you high frenum attachment, and here this is showing you again a frenum attachment. So these are cases where you have compromised width of attached gingiva. So that means we have to treat this, we have to correct this so that there is no further gingival recession. So this summarizes the entire case sheet, what you need to take for your clinical diagnosis. And based on this, now you will be able to give a diagnosis, which will be a provisional diagnosis. And then you will also do, if required, you need to take x-rays, you need to take your investigations, and then you will come to a final diagnosis. So you will now see whether it is a case of gingivitis, plaque-induced gingivitis, or it is a case of periodontitis. Thank you. I hope you all understood.